Pyelonephritis, abbreviated XGP, is a rare inflammatory pathology of the kidney in which normal renal parenchyma is replaced by fibrotic tissues and histiocytes. It most commonly occurs in the setting of chronic obstruction, pyelonephritis, or immune dysregulation, and often progresses to loss of renal function requiring radical nephrectomy. We present the case of a 26-year-old woman with long-standing nephrolithiasis in her second trimester of pregnancy who developed likely XGP secondary to obstructive Proteus mirabilis UTI. As you can imagine, her pregnancy complicated standard diagnosis and management. XGP is quite rare in a young pregnant patient, so we hope that her clinical course and treatment may help inform future challenging management cases like hers. Only 0.6 to 1% of all chronic renal infections are diagnosed as XGP, which is the invasion of renal tissue by lipid-laden macrophages leading to fibrous and fatty replacement of renal parenchyma. This occurs following repeated infectious, inflammatory, and obstructive insults in predisposed patients. XGP often occurs in patients with risk factors for frequent UTIs and obstruction. That includes middle-aged women, those with urinary outflow compromise, diabetics, immunocompromised patients, and those with dyslipidemia. The clinical presentation is indistinguishable from pyelonephritis with flank pain, dysuria, urinary frequency, fever, chills, and leukocytosis. XGP is classified as either focal, segmental, or diffuse. Diffuse XGP is further staged as either stage 1, nephric disease contained within the kidney, stage 2, perinephric disease spreading to the perinephric fat, or stage 3, paranephric disease extending beyond the kidney through fascial layers into the liver or surrounding soft tissues. Diagnosis can be strongly suspected by imaging studies, usually with CT scans in non-pregnant patients. MRI is very rarely used in the diagnosis of XGP, and so its signal characteristics are poorly reported in the literature. Treatment of XGP is almost always surgical removal of the affected non-functioning kidney. Now we'll discuss our patient's case. The patient is a 26-year-old female, G3-P2, with a history of recurrent kidney stones and complicated UTIs, who presented to our emergency department with a 1-month history of right flank pain associated with fever, chills, night sweats, and fatigue. 3 weeks earlier, she had presented to a different local emergency department where she was diagnosed with obstructive pyelonephritis and discovered she was approximately 12 weeks pregnant. She left against medical advice, taking a 2-week course of oral antibiotics as her symptoms progressively worsened at home. She received no prenatal care throughout this time and was hiding the pregnancy from family. Upon presentation to our emergency department, renal ultrasound demonstrated a 20 by 10 centimeter hydronephrotic right kidney with significant cortical atrophy and multiple stones that you can see here in figure 1. Notice the characteristic bear's paw print sign from the dilated calyces. The patient was hemodynamically stable with no leukocytosis, but with a mild AKI. Fetal ultrasound showed a viable 16-week gestation. We started the patient on piperacillin tazobactam. The next day, the patient underwent percutaneous nephrostomy tube placement with drainage of profuse frank pus from the right kidney. If you'll bring your attention to figure 2, you will see her intraprocedural contrast pyelogram. 30 minutes following tube placement, she became acutely distressed with rigors, severe flank pain, and fetal tachycardia. Blood cultures drawn at this time ultimately grew Proteus. She was sent to the ICU. CT was contraindicated in pregnancy, so we collected the MRI images you will see in figure 3. Figure 3A demonstrates the percutaneous nephrostomy tube coiling within the dilated posterior calyx of the right kidney, which is filled with a slightly heterogeneous, enhancing fluid. The renal cortex in all 3 sequences is severely thinned with signal abnormalities compared to the normal kidney. Note the perinephric fluid and surrounding soft tissue edema, suggesting that this is diffuse stage 2 XGP. Also note the partially visualized fetus in the uterus on the 2 coronal images. The patient was subsequently treated with IV antibiotics per susceptibilities. Midline catheter was placed. Following IV antibiotics, she will take suppressive oral antibiotics for the duration of her pregnancy. And that's where the story ends for now. The plan is that she will get renal scintigraphy after delivery and will likely need total nephrectomy. I would like to discuss how unusual this case is for a young pregnant patient to develop likely XGP secondary to chronic nephrolithiasis in the absence of other classically described risk factors. She could not undergo typical diagnostic imaging with CT because of her pregnancy. Definitive surgical management has to wait until following delivery of the fetus because of the high risk of fetal demise. This means the patient has to continue with nephrostomy tube care, prolonged antibiotics, and multi-specialty follow-up appointments for several more months. She remains at risk for septic abortion, preterm labor, or fetal growth restriction. It remains to be seen how this case concludes. XGP is a rare and severe renal pathology that poses significant challenges, particularly in unusual settings such as pregnancy. It is important that the differential include XGP. Be familiar with the key imaging characteristics of XGP, even in unusual modalities like MRI. Hopefully, this case can help inform diagnosis and management of XGP in other patients in the future.